David, how are you?
I'm good, Todd. How are you?
I'm doing well, thanks. So it's been a while since we've talked. We have a lot to cover.
There are a great many things that have been afoot.
So maybe we can start with what's happened since the last time you and I chatted. What's at the top of your list?
This is not very imaginative. The top of my list, I have to say, has got to be the emergence of the new Omicron strain within COVID and the legal battle that we are seeing over mandates, vaccine mandates, and particularly those for healthcare workers.
So I do agree that's a good place to start. So what's your sense as to how this is going to play out over the next month or so?
Well, it's very interesting because you have two different cases that have made it to federal court on just the issue of healthcare workers getting vaccinated, and that's about 17 million people in the United States who are affected by that. But it's one of the courts that made the decision is in Missouri, okay, and the other federal court is in Louisiana, and they both put a hold on the Biden administration's efforts from CMS to impose the mandate real fast. Louisiana's in the fifth district, the Fifth Circuit for the federal judiciary, and Missouri's in the eighth. So they're two Supreme Court people who are assigned to oversee what comes out of them. Out of Louisiana, it's Justice Alito, and out of Missouri, it's Justice Kavanaugh. So I mean, at some point, I would imagine they're going to want to put these together and try to move very quickly. But it's just, the idea that it could be all straightened out before the holidays, I just don't see it, but it's not impossible.
So as I think about this from the perspective of first the Biden administration, then Congress, what does this mean in terms of other agenda items?
As you know, everything with COVID has become so politicized that it's really hard to kind of like know exactly, where one controversy is going to stop and where another one's going to end and begin. And that kind of leads me to the second thing that I was going to bring up, which is the massive shortages we're seeing in healthcare in terms of workforce. And maybe I shouldn't say massive, but significant. And it's not all COVID. If you listen to the chief medical officers that we convene calls with, ASN does, in nephrology, every week, it does seem to be other factors also that are just an aging workforce that is retiring out. And as we've talked about before, and other members have talked about before, which is that the way in which the healthcare system has been strained in during COVID has really made it clear kind of how kind of close to the edge we may be living with a healthcare system that's really not able to handle big issues like this. Does that make sense?
It does. I mean, I think it points also to not only the aging of the healthcare workforce, but also the fact that if you take a step back and you look at people's savings and what's happening with the markets, and, they've gone in one direction, and that's up over the last 18 months or so. And so you then also have the issue of people feeling more comfortable stepping away from the workforce, either retiring, as you said, or looking at other opportunities. I guess the other challenge here is then how long it takes to build the workforce, and because of the educational pipeline and just a sheer amount of time. So I know there's some proposals in Congress. I know there's ideas, at least with the Build Back Better legislation, around trying to provide additional incentives for people to pursue healthcare careers. Again, what do you think is going to happen here?
And I know that we've got some really big issues to face in the next couple of weeks, like the federal debt ceiling. And the politics is such that it's become so poisonous. It's hard to imagine Congress stepping in and really doing significant work other than just, real stopgap measures. So I'm not very optimistic. I'm more optimistic that the courts will get their act together and make decisions than I am that Congress will. And that's we've talked about this because it's not just shortages. I mean, even within the Medicare system, there are just mandatory cuts that are on the board that everyone thought would get addressed. And you even challenged me a couple months ago to say whether we thought we would get an answer out of Congress, and I said absolutely. Well, I kind of still feel absolutely, but the catch is it may not happen until the first quarter of 2022.
And I guess before we discuss those cuts, just to sort of close out these two issues, because I do think that they relate, it seems like in all likelihood, we're just going to have, I don't know if this is going to be based on individual community, individual states, or individual regions, but it seems like we're going to have parts of the country which are going to have required vaccine mandates or masking mandates. We're also going to have parts of the country where that's not the case. And at the same time, we're going to have parts of the country where there's real shortages in healthcare workers and in other parts of the country where there's not. And I think if you take those two maps and sort of lay one over the other, I think there's going to be a fair amount of correlation. And I just don't know what that means in terms of both the midterm elections, but also as we think about just the future of the country.
Yeah, that is a really, really good point, and I still want to see a really good map of exactly how that's going to all overlay. And I just wanted to say it's not just healthcare. I mean, the number of people who are deciding to walk away from their normal 9 to 5 employment is pretty significant, and there does seem to be a real movement trying to find something that would be independent for them. We were talking recently with the chief medical officers about certain things, and they were talking about some of the supply issues that they're having. And one of the things that's really been very hard for most people to get their heads wrapped around is just a very large number of people who have left the trucking industry and just do not want to be driving trucks up and down the highway anymore. Don't want to be away from their family that long. There's just a lot of things that I think a lot of kind of nerves of the social fabric that have been kind of laid bare and are kind of chafing against people, and they don't want to be uh, participating in the system as the way it's structured now.
David, I want to circle back to the forthcoming cuts to the Medicare program and to physician reimbursement. Can you just remind us what the issue there was and where you were so definitive a few months ago that Congress would step in and fix this problem?
Yeah. You get to razz me some here. Yes, one of the things that happened was there were changes in the in evaluation and management codes that occurred that were supposed to take effect in 2021, and Congress stepped in and delayed them, and that included a 3.75% conversion factor that's used in the Medicare overall system, which is well, not that number every year, but a conversion factor. And that conversion factor was placed on hold without any further action from Congress. It will go into effect January 2022. We thought Congress would pretty much have stepped up by now and taken care of it. They have not. Then there's also, a pay to go, enforcement number in terms of what's on the books for Medicare, which could add another 4-5%. And then there's some other ones that have to do with things like the facilities in which we do lots of the vascular access procedures, and I won't go into all of that. It's complicated, but it's something that ASN has joined other groups and gone to the White House about and talked about, and we're really hoping that some adjustments are made there. So some of them might be last minute Congress, some of them might be some things that OMB can do. I don't. We're still kind of waiting to see, but either there'll be some real good news or there'll be some other moments saying you got to hold on, and we'll see what's going to happen shortly.
Yeah, it's interesting. I'm having a little bit of a deja vu moment in the sense that this is what used to happen almost every year, where cuts would automatically go into effect, and then sort of Congress would intervene and sort of replace or undo the cut and sort of put back, sort of make physicians whole. Sounds like that's the best we're going to do this year. Is that they'll go into effect, there'll be cuts, and then Congress at some point possibly will step in, although that's not a guarantee.
That's exactly right, and you're exactly right. You are seeing deja vu, and I've seen it. You've seen it, and it is like we've returned to where we were 15 years, 20 years ago, and the system has worked better for some period of time, but the catch is it has now started to run up against the realities of a budget neutrality system for Medicare. So we'll see what's going to happen, but like you said, there's a battle for the heart and soul of a lot of things going on in Capitol Hill, and there's one going on now with FDA.
Yeah, so maybe we shift there and you kind of remind us as to what that issue is.
FDA has had an acting administrator for some time now, and it is time to make a decision. Dr. Janet Woodcock had served as the acting administrator and had done a very good job. But there are people, including the person who's been nominated, Dr. Robert Califf, who were on the watch during the opioid crisis, and some members basically say, anybody who was at the FDA and on the watch during the opioid crisis should not be coming back in to run the FDA. There are other issues involved, of course, but you and I have talked about this before, that this is something that usually was a fairly nonpartisan vote. And we think those days for now have ended, and that these will become very narrow partisan votes for things like FDA commissioner.
Yeah, the only comment I'll make there is that there are a lot of members of Congress who are on the watch and in office during the opioid crisis and bear responsibility. And to my knowledge, none of them have stepped down or not continued in terms of their serving for reelection. So that seems like a little bit of a one-sided argument. And I'll just leave it at that before I get myself in trouble. One other issue before we move on is the mandatory model and sort of what's happening there. Can you just kind of bring us up to speed on that issue?
I want to be very positive about the direction that we're going in here. And that is that the Innovation Center at CMS that designs the models for testing wanted to see what it could do to address issues of equity. And since equity is and you've been working for a couple of years now with NKF and with lots of our members trying to deal with equity issues, particularly the use of race in the EGFR equation. So they wanted to do something. And so what they did was they said, well, what we're going to do is we're going to take, in the mandatory model, we're going to take practices and facilities. So it could apply to both the nephrologist practices and the dialysis facilities. And we're going to stratify them. So one stratum is that in your group, if you have over 50% of the participants in your group, the Medicare beneficiaries, the patients, if over 50% of them are either dual eligible for both Medicare and Medicaid, which is usually attributed to some of the lower health outcomes that we see that are and lower access also. And the other one is low income support devices that are provided by states. So if you've got 50% in those categories above, in your group, that puts you to top stratum. The bottom stratum is if you have less than 50%. And so what they want to do is they want to use that cutoff to kind of make special efforts and include payments to adjust to really help, particularly those areas with very large numbers of dual eligibles, very large numbers of individuals who've not had historically the best access to healthcare, and also probably don't have the greatest access to financial resources. So that is the thing that everyone is very, very glad to hear, is the objective here. I think where everyone is getting a little stuck on this is what is the difference between 51% and 49%? And how do you advance equity with such a narrow margin? ASN argued that there needed to be more breakpoints, and it needed to be calibrated with a little bit more finesse. I think a good portion of the kidney community argued for the same thing. This was one of those situations where the government said, basically, that's hard. It's hard to do. You have a hard time just the double standard of basically, FDA was, had people on the watch, and Congress had people on the watch during the opioid crisis. I have a really hard time when the government tells us, particularly in a mandatory project, that's too hard to do. I just have a real problem with that. It's like, if it's too hard to do, then, we need to be talking about the program. But it's a fantastic attempt, and that's great. We're going to have to see how much nuance it has and how much it can help on equity. But it is the first time that they have actually made an adjustment that was based on equity and will be seen in payment and in regulation. In the past, it's just been risk adjustment for patients who are considered higher risk. And those things generally let you off with a lighter load. The catch, and we'll just say this because, when our people start to see it, it is going to have a fairly significant difference between what the levels of success are in the program for those people with the large number of dual eligibles and those who are we have far less. So I mean, there will be some significant differences in the ranges of like, one's got a range of like, got to improve by 5 or 6 points, and the other one's got to improve by 10 or 11 points. Now, I'm taking those off the top of my head, but there are some like that, and so there are some significant differences there, and it is gonna be something that we're going to have to all watch and see how it works.
So it sounds like best case scenario, this is a first, if crude, attempt to try to address equity within the mandatory model, and that over time, as CMS has more data and there's more sort of understanding of the instrument, there might be a way to refine it, make it more nuanced. And the worst case scenario is that it's such a blunt instrument and it's in a mandatory model that it sort of brings down the sort of crashes the entire attempt at change in this arena, and it becomes an utter disaster. I mean, are those the kind of two extremes here, or is that, am I overstating it?
A little bit overstating, but not that much. I think one of the things that could be really sad is that it could be kind of arbitrary enough that at the end you can't really look at the data and tell anything, and that would, or you can't tell much, and that would be very disappointing. I think for our members who really do want to see they do want to see the evidence, and they do want to see us monitoring and figuring out which steps are effective. And so, our listeners can know that we are going to stay on this. And we already reached out after these were released just the other day, and we asked CMS if they were going to do some instructional sessions, webinars, and so forth on this. They've answered they hadn't planned to, but they would consider it, and we are going to try to continue to get them to engage with our members over this particular issue so that they have a better idea of what's happening.
So earlier you had mentioned the National Kidney Foundation, and I just wanted to close. My counterpart there is Kevin Longino, and Kevin and I recently published a editorial in Health Affairs, their online version. And I think what's important is if you look at the healthcare arena, because most of the medical journals have sections focused on health policy, there aren't a lot of health policy journals, and Health Affairs really is the leading one. And so the fact that they were interested in a commentary around policy issues in the kidney arena, I think is really exciting. And so basically, we focused mostly on the appropriation side. That's something we haven't talked as much about today, and maybe we can do a quick update. But essentially, what Kevin and I did is in this editorial, we made a couple of requests, and the first was to increase funding for kidney research at NIH, particularly the National Institute of Diabetes and Digestive and Kidney Diseases. The second was to increase funding for Kidney X, which of course is the innovation accelerator and the partnership between ASN and the Department of Health and Human Services. And the third, which is one you and I haven't talked as much about, is that the Centers for Disease Control and Prevention has a chronic kidney disease initiative, which really is a unique place in the government to raise awareness and address specific issues related to kidney disease. And so, we made the request, to Congress to really pick up each of these appropriations opportunities and fund them appropriately moving forward. I think the good news is this is a rare area where there is bipartisan support, where there is bicameral support. And really what we're hoping is to increase the levels in the hopes of really funding these such that we can continue to innovate and provide hope for the future. So let me stop there. Just wanted to flag that for everyone, but ask you sort of as a closing question, kind of what you see with appropriations discussions as we move forward.
Well, first of all, let me compliment you and Kevin Longino on an excellent op-ed. And if our listeners have not read it, they go to Health Affairs and Google your name. And it's a really good article, and it really does lay out very clearly what the two organizations and its members think are really important steps that Congress needs to take at the moment. And I think in this area, probably we have a bit more. I'm feeling a little bit more like the glass is half full. I think it's going to be very, very, very hard to come out of what we've been through and basically claim that all of our preventive efforts and research and in any of the forms are up to speed, up to snuff. And with the numbers that we have in the United States for the number of Americans, with 37 million Americans probably impacted by kidney disease, those are pretty big numbers. And the idea that we're going to let this continue on at a funding pace that looks to me more like the early 1980s when I started on Capitol Hill is kind of, I mean, I think the chronic kidney disease initiative at CDC is right now at what, $2.5 million.
That's right.
Yeah, $2.5 million. I'm not. I would love for to get a check for $2.5 million tomorrow. So I don't want to in any way impugn that money, and I know it takes a lot of taxpayers' money to get there. But when the federal government is dealing with problems of this significance and of this cost, and like we say, 130 billion in Medicare alone on kidney diseases, and that we're not even beginning to capture everything in veterans, Indian affairs, so forth. So there's a lot of good economic sense behind these things, as well as being a part of doing the right thing. So I think the timing was really good. I think what your message, the message the two of you had, was very clear, and I think that it's kind of. I would love to see all of our members, take it out, take the link and put it in an email to their members of Congress and say, I hope you read this.
Yeah, it's interesting. I should have also mentioned it. We started this discussion talking about the COVID-19 pandemic, and the sort of fourth point, in addition to NIDDK/NIH, Kidney X, and CDC, is we did mention that NIDDK was one of the few institutes at NIH that didn't receive research funding in the different COVID-19 packages during the past year, and so one of the points we try to do is say, how important this issue is from the perspective of the kidney disease, people with kidney diseases, and that there needs to be, any sort of future funding for COVID-19 needs to include, the kidney community. And so, we'll sort of close where we started. David, I'll give you, as always, the last word. Anything you'd like to say as we sort of close out today's discussion?
Well, 2020 was supposed to be the year from you know what. 2021 was supposed to be a lot easier. I'm just real curious as about what 2022 is going to look like, and I think we're all going to join in and keeping our fingers crossed.
Well, David, as always, thank you.
Thank you.